All right, so we're going to get started with chapter 12, which is the chapter on the respiratory system and specifically conditions, disease processes affecting pediatrics in terms of respiratory functioning. This is a rather lengthy chapter, and so I am creating two separate voice recordings. Basically, I have the chapter divided into two parts, so there'll be a part 1 and a part 2, which is similar to what was done for chapter 20, which is the hematology immune function disorders, as well as the neoplastic or cancer content. And as always, we have our learning objectives that we'll plan to explore throughout this chapter and this lecture, primarily recognizing the differences in the pediatric patient from the adult patient. Obviously, a lot of it to do with the immaturity of the immune system, the immaturity of this respiratory system, and why that makes children more susceptible to all of these different conditions and diseases. And then also how these conditions and diseases present in the pediatric population, some of these being some of the same kinds of things you'll see in the adults, but it might manifest differently, it might be managed differently, there might be a different outcome expected when it's a child versus an adult. And then what are some of the important education components that the family need to know about in relation to these different disorders. Okay, so this image, I don't recall this actually being in your book. I think I am using this elsewhere, but this is an image that is meant to just illustrate for you the anatomy and physiology of the respiratory system, specifically the upper airway, which is the passageway including the nasopharynx and the oropharynx, so nose, mouth, and throat, all of which connect to the ears by the eustachian tubes. The nose, pharynx, and larynx are separated from the lower airway by the trachea. So when we're talking about upper airway disorders and lower airway disorders, it's important to note what structures fall into each category because it can help you to better identify what are the manifestations you would anticipate if what's involved is the upper airway versus if it's the lower airway. So upper airway includes your nose, your throat, the larynx or voice box, and then it's separated by the trachea. The lower airway includes the bronchi, bronchioles, and alveoli, so it is primarily the lungs, and the trachea is that separation as well. And so basically a recap of what was just said, and you'll see that on this illustration, the trachea is included in the lower respiratory tract. It is the separation between the two, but in most literature, it does group it with the lower airway just because of its location. Some things to review are the A&P of these different structures, like how cilia and mucus are there to warm, clean, and humidify the air. The epiglottis is the structure that covers the vocal cords, and I think there's a few others that we'll look at too. This is looking at the same illustration in terms of the lower airway, which we said was the trachea, bronchi, bronchioles, and alveoli. The left lung, remember, has 2 lobes. The right has 3. The left is at a sharper angle. The bronchi split into branches known as bronchioles, and the left bronchi splits at a sharper angle, which is important to consider in cases of, foreign body obstruction. It's more likely for things to be lodged there. The terminal bronchioles end in alveoli sacs that are surrounded by capillaries, and this is where oxygen and carbon dioxide are diffused. Surfactant, remember that's the phospholipid in the alveoli that's keeping the alveoli pliable, allowing the lungs to collapse completely and expand or recoil for optimal oxygenation. And then the rib cage is what's protecting the lungs. The lungs are surrounded by muscles in the thoracic cavity, and the diaphragm muscle separates the lungs from the abdominal cavity. The diaphragm being what contracts, creating the negative pressure that's pulling air into the lungs. The lungs and chest wall actively expanding with inspiration and then returning to a resting state with expiration. So remember, normal breathing is primarily involuntary. There's no thinking process to it. But obviously, when we have adjustments in the respiratory rate, heart rate, the output that our lungs are capable of, that's going to affect the gas exchange, whether that's adequate or not. And it does require equal ventilation and blood distribution to maintain adequate gas exchange. And all of this would come in your patho course, your A&P courses from prereqs, but there's also some information about this at the beginning of the chapter that kind of just reinforces it. Excuse me. Okay, this image is great because it actually does a side-by-side comparison of the adult structure versus the pediatric, so pay attention to it. I'm not going to read it to you, but it kind of speaks to some of the differences, like how the tongue is, larger in comparison to the adult's tongue, as far as, tendency for obstruction. It talks about how the nares are smaller in the child, which means they become more easily occluded. The, shape and positioning of the eustachian tube. So just look at this to get a better idea of what are some of these important pediatric differences. Okay, so kind of in summary, the things that, want to point out, the babies we discussed have the tendency to be obligatory or primarily nose breathers. Obviously, they can be oxygenated adequately with their mouths, but they don't know that necessarily. And so we talked about how important it is to make sure that is patency for the nares, and that's why we discuss saline and bulb syringe and, those measures. The same is true in discussing the airway as far as the throat or the oral passageway, because it's a lot smaller in diameter than what you've got when you're an older child or an adult. And there's some, pictures here to kind of just put that in perspective for you. Normally, if we were in class for this content, I'd provide you with straws, and I'd have everybody hold their nose and try to breathe solely through the straw for a minute and see how that feels. Because what you should find is that it's a little bit more challenging to do that because that airway is so narrow. In fact, you can think of an infant's airway as being the size or the diameter of a drinking straw. So when that airway experiences any kind of obstruction, inflammation being the primary one, then it can drastically reduce that airway. This image shows you that, basically if you have 1 millimeter of circumferential edema or swelling around that airway, then it has just reduced the diameter, the opening of that airway by 50%. Whereas when it's an adult with that same amount of edema or that same amount of swelling, it's not creating that great of a reduction of, diameter, radius, increased pulmonary resistance, because they had a lot more to begin with, a lot more area to begin with. Some other things to note is that, like, a child's airway, and this isn't a specific aged kid, but like just when we're kind of outgrowing the infant size, if you will, could be comparable to the size of a person's little finger or pinky finger, which, is obviously going to be different depending on whose finger you're, measuring. But this again is why it's so important to think about when kids are eating solid foods, what kind of foods are they eating and how are we preparing them? Because things like grapes and popcorn and hot dogs can easily get lodged in that area and become a complete obstruction for the patient. So sinuses are still developing. We talk about abdominal wall movement, how that's, pretty standard. So you'll see that. That doesn't necessarily mean there's any accessory muscle use for that child. It's just because of their size that you see it. Depending on what's going on, sometimes apneic or cessation of breathing episodes can be anticipated, especially in the first few months of life. Whereas if it persists, it would be a concern. The child's airway is shorter, is narrower than the adult airway. Let's see what else. The larynx is more flexible than the adults, and is more easily stimulated to have spasms, which means it would, potentially narrow or close. The child's intercostal muscles are not fully developed, which is why we see that abdominal wall movement with respirations generally until about age 6. Let's see, newborn period is typically when apneic episodes will occur. They actually call it apnea of prematurity or newborn apnea, and it's typically not concerning in those first few weeks of life. The child's metabolic rate is greater than the adults, which means their oxygen demand is higher, and so they require more supplemental O2 if O2 is needed than the adult patient usually would. It's also why their respiratory rate is so much faster and can have an irregularity or irregular pattern to it. Newborns do not have the defense of bronchospasms that are intended to trap, foreign irritants or pathogens because of the smooth muscles not being fully developed until about half a year old. So that can also contribute to their likelihood of infection being more frequent. I'm not going to go through all of these, just look at these other differences, the amount of alveoli present in birth or infancy compared to an older child, how the bronchi bifurcate or split, the flexibility of the cartilage, talking about the ears, which I know this sounds like that's a respiratory chapter, but that's going to also be part of this content. But the fact that they're shorter and that the eustachian tubes are more horizontal is the reason for more infections in kids and more likely to have injury. If it's shorter, then that means anything that they're trying to stick in, they can do more damage because they don't have to go very far, and they're going to potentially come in contact with the tympanic membrane. The fact that they're more horizontal means that they don't drain as easily. So when there is fluid that accumulates, due to sinuses or after swimming or whatever, it doesn't as easily drain to the back of the throat and be reabsorbed elsewhere. It stays stagnant. Well, stagnant is what's going to develop bacteria and viral infections. The comparison of lung volume in proportion to their chest size. Tonsils are larger in comparison to the adult, shape or body. Chest diameter, those differences, just pay attention to that information as well. So this is actually an illustration of the eustachian tube comparison and that more horizontal positioning that I referenced. I didn't mean to click on that so quickly, and for whatever reason, I can't go backwards when I am recording, apparently. But there was some description in the illustration, some little captions that talked about the infant versus the older child or adult eustachian tube and ear canal. So please pay attention to those things. Okay, in terms of respiratory disorders, we're going to speak to the patient's medical history, that includes family history, their environment on a routine basis, their patterns of care and development, even milestones, because all of that can factor into the patient's respiratory functioning. When we're looking at the patient having recurring symptoms associated with respiratory problems or distress, we want to know, like, how long has this been going on for? What were the circumstances of their environment? Like, are they in daycare? Are they in a home with pets? Do people smoke in the home? Does the family have any medical history, especially chronic, like asthma? What is the patient's sleeping patterns and eating patterns? Because again, all of that can have an impact on respiratory disorder formation. When we're talking about assessing respiratory effort or the work of breathing, there's a lot of different criteria that we can look at and evaluate to kind of determine the severity. And it's should be familiar to you that there are different severities of respiratory distress. There's mild, moderate, and severe. Respiratory distress ultimately leads to respiratory arrest, which is fatal. And so when we're talking, and that essentially leads to respiratory failure, which is when a patient requires CPR, rapid response, all of those things. So our assessment should focus on things like, what's the effort needed for the patient to adequately oxygenate themselves. That can be determined by looking for evidence of retractions or other accessory muscle use. Negative pressure is what's creating the movement of the diaphragm when it's taking in air and that chest wall is pulling it inward. So when that is increased because there's greater demand, then we see those retractions created. The retractions can even be subcategorized to determine distress levels, like mild, moderate, and severe. For example, intercostal retractions, which are the ones on this illustration between the ribs, are the representation of mild distress. That's usually the way they initially present. As the distress worsens, the child's retractions will worsen to include substernal, subcostal, which are shown also on this illustration. That's the ones that are further down on the rib cage. And it can get to as severe as suprasternal and supraclavicular, which are the ones high on the trunk, and those are the indicators of severe distress for the patient. Other ways that you can tell if a child's in distress, especially babies, since they can't verbalize the difficulty breathing, would be watching their nose. We talked about nasal flaring before. The sounds they make while breathing, like grunting sounds. They will have changes in their vitals, like tachypnea. They'll have an increased respiratory rate. Tachycardia, we would expect them to have an increased heart rate. They could even have what's called paradoxical breathing, which is like seesaw breathing. It's the diaphragm moving the opposite of what you would expect with normal ventilation. Anytime we are suspecting distress in the patient, we want to, create the optimal positioning for the patient, because that's going to allow for the maximum lung expansion and airway facilitation. So that's a child that's elevated in the bed. That's not a child who's laying flat on their back or even semi-Fowlers, because that's not going to provide the optimal lung expansion for that patient. We're looking for symmetry, like symmetrical chest rise, because if we see something asymmetrical, generally it's an indication of like a lung collapse or, a tension pneumothorax is formed, and those have different interventions needed for them. The color of the skin, the hydration status of, say, like the mucous membranes is important. What do the nail beds look like? The tip of the nose even. The nasal flaring we mentioned, they widen with inspiration when there's distress. Skin color changes obviously being crucial in assessing functioning of the respiratory system. Pallor or paleness could be indicative of even a complication like anemia, whereas like cyanosis is generally a indicator of hypoxemia or low oxygenation in the bloodstream. We talked about acrocyanosis. That's a normal cyanosis in newborns in the first, you would remember hopefully, 48 hours of life, but beyond that would require further evaluation and follow-up. The breath sounds that we're auscultating, we would hope that they would be clear bilaterally, but typically with respiratory distress, there's some form of adventitious or abnormal breath sounds, and those can range. You've learned about these before. We're going to be, emphasizing them again, but there's things like crackles, which also is referred to as rails, and is this fine crackling noise you hear generally on inspiration, associated with air moving through the fluid-filled alveoli, like in the case of pneumonia, for example, or congestive heart failure, which is more the adult CHF than the patient that's pediatric ages. Sometimes you'll see some relief with coughing, especially if it's productive, but generally it's going to remain. If you simulate the sound of like rolling your hair between your fingers, that'll kind of capture what that crackling noise sounds like. We also have the adventitious sound of bronchi, which is more like a snore. It's a lower pitch, deeper vibration, and that's associated with mucus. So as air passes through thick secretions, then that's the sound that results. And this one does often clear with coughing, especially productive coughing. So you could be hearing it and then the patient could cough, and now you don't hear it in that same location. You hear it elsewhere, or you may not hear it at all anymore. Stridor. Stridor is the one that indicates the most severe respiratory compromise. It's the high pitch sound that you hear with inspiration, and it's often due to upper airway obstruction. So either foreign body aspiration, like they swallowed something and it's lodged in their airway, or like croup. Anaphylaxis can progress to this. I'm trying to think what else. You can even have stridor that's not acute, that's chronic in nature. And we're going to have some conditions, we speak to that a little bit later, but it's structurally associated with the narrowing of the airway, either the trachea or the larynx or both, or the floppiness of that cartilage that comprises those two structures in the airway. And then the last adventitious sound would be wheezing, which is the one that's also high pitched but more musically inclined. You can hear it with inspiration or expiration or both. It does obviously indicate some need for intervention, but it's not to the point of severity of stridor. And this is occurring usually when there's inflammation that's constricting the airway structures, like the bronchioles. They're more narrow. And a good example would be asthma is typically going to result in wheezing. So what are we doing for this patient? Suctioning is important. And remember we talked about suctioning can be suctioning with a bulb syringe of the nose or mouth, but also a suction catheter, like what you're thinking of with the Yonker, which is that suction tube in plastic. But they also make catheters that are very pliable, a lot like a Foley cath would be, but way, way, way narrower in diameter, and they can reach the hard to reach places and retrieve some of these secretions that are potentially keeping the patient from breathing adequately. Let's see, speaks to the fact that kids may not know how to cough up or blow their nose to remove secretions, and that's why it's really important that the nurse or other healthcare provider recognizes when suctioning is needed. Suctioning can be very frightening for the child as well as for the parents, and they usually have to be secured or restrained enough that they're not gonna move in the wrong direction and potentially cause injury to themselves. While they're being suctioned, it's literally interfering with oxygenation. So they'll take their breath away, which startles them. It often makes them cry. And if you have a patient who's not cognitively able to demonstrate that, you have to be aware that, like, when you suction, you can't do that for more than 10 seconds without giving that child a break, because then they will become cyanotic because they won't be able to have the normal ventilation abilities. Palpation, we talked about that in this system when we're looking at like lymph node enlargement, especially in the head and neck. That's typically where we're going to see that change because it's close to that respiratory tract or system. Those lymph nodes are always there, but they're not generally palpable. They're not generally enlarged enough to be felt or seen. But when they do become enlarged, it takes a long time for them to return to their non-palpable, non-visible state. And so you'll typically notice them for a while. The sinuses in children, especially older kids, we want to assess for tenderness. So that's like palpation on the face, because a lot of times they are experiencing some form of irritation or infection. We talked about allergies being very common in the school-age child, and so that's one of the ways it'll manifest, is creating that tenderness and that inflammation to the sinuses. I want to draw your attention to a box in the book on page 220. It's box 12.1, and it does a good job of listing out the indicators of respiratory distress and failure and kind of distinguishing the two. Remember, distress being less severe, failure being, leading to arrest. I think I might have said that backwards earlier, but respiratory failure is what precedes respiratory arrest. It's the more severe form of distress. But we've talked about what pretty much most of those interventions look like already. If a patient, just as an example that I've thought of to share, if a patient is experiencing respiratory compromise and they're having a slow and shallow breath rate, so they're actually, instead of tachypnic, you would consider it Brady. That is actually an indication generally of respiratory failure, which is worse than distress because it means that the lungs cannot compensate anymore. And so we're past the point of them being tachypnic and tachycardic, and now the body's essentially shutting down, like they can't do anything more to help the child. And it's obviously very much an emergency because they're decompensating. Know the difference between hypoxia and hypoxemia, one being low oxygenation of the tissues, the other in the blood. With respiratory failure, we also see mental status changes. Patients are generally very, very irritable. We see more of the mottled skin color. The patient may be lethargic as far as their mental status capacity. If they're coughing continuously, that's concerning because that means they're never getting, adequate air exchange. Their retractions are going to be the supraclavicular and suprasternal form that indicates more severity. If they're quietly breathing, if they're quiet breathers, that's not a good sign. That's not improvement. That is generally indicative, again, of that inability to compensate any longer. Same for if they were to have what we would consider normal respirations, but all these other indicators, that's poor prognosis at that point. Sometimes they'll assume a position of comfort that allows for, the best breathing abilities, and we refer to that position as the tripod position. We'll see it with patients, especially when they have epiglottitis. And they'll put their arms or their hands on their knees. They'll extend their neck, their whole body forward, and it's basically like air hunger. They're gasping for air at that point. I mentioned seesaw respirations or paradoxical breathing before as another indicator. That is usually in the category of failure, so worse off than just a distress patient. Let's see, weak or absent cry, etc. And then I have on this slide other assessment measures would be pulse oximetry, obviously, a non-invasive measurement for oxygen bound to hemoglobin, which tells you your oxygen saturation, and we know normal should be between 95 and 100. It's very rare that anybody is just like satting at 100. So don't think that somebody at 96 or 97 is in distress. That's probably closer to their norm. But you can apply the probe for that to different places, the nail bed on the finger, the tragus or actual pin of the ear, the wrist on a small infant, the feet of a small infant, and we'll look at some illustrations of that towards the end of this chapter. ABGs, arterial blood gases, would be a more invasive method of getting the patient's oxygen saturation. Obviously, it's anxiety provoking for the kid and the parent, so we want to avoid it if we can, but it is a more accurate diagnostic measure. So, if we need to know just the severity, this is going to help us to be able to interpret if the patient's experiencing acidosis or alkalosis, those kind of things. It'll tell us, hypercarbia, which is acidosis, versus hypoxemia, decreased oxygen in the blood, and whether a patient's responding to supplemental oxygen. There is a table, 12.1 on page 222 in your book that deals solely with supplemental oxygen, the ways in which it can be administered, things to consider. So I would definitely look at that table as well. Let's see. We want to pay attention to the patient's pulse, the quality of it, if it's weak or normal, fast or regular. Same with their respirations. What's the speed and rate and rhythm? Is there any accessory muscle use? What's their color? Are they coughing? Is that cough productive? Does it indicate, possible foreign body obstruction? What's their behavior? Are they lethargic? Are they irritable? Are they having changes in their LOC? Their dehydration status? Are there indicators of shock for the patient? All of these things helping us to have a better understanding of the severity of the patient's respiratory function is in and what measures are needed to improve it. Okay, and then now that we've kind of covered like the, introduction to the respiratory content, we're going to start looking at specific conditions. Each slide has been basically categorized by like where in the body it's impacting the patient. So this first set of disorders is upper airway, and these are all infectious disorders, and then we'll have upper airway non-infectious disorders, and then we'll have for our second recording or voiceover, we'll get into the lower airway infectious and non-infectious conditions as well. So I tried to group them, in this manner for a few reasons. One, if you can pay attention to whether it's impacting the upper airway versus the lower airway, then generally you can better anticipate what are the patient's clinical presentations going to be, like what are the signs and symptoms you can expect, what's the management that's going to improve those signs and symptoms, and then knowing whether it's infectious or non-infectious obviously is important to whether the patient's likely going to be hospitalized, if they need to stay home from daycare and school, what other complications might you anticipate as a consequence of these different disorders. So that's the approach I took. There's a lot of different textbooks out there that do it different ways, but this is how I chose, and I don't honestly remember if this is also how the book does it, but this was the way that I thought was the most logical for presenting this content. Remember, this is probably the largest chapter as far as amount of information that you will get this semester in pediatrics, because respiratory is a huge deal, and it typically is what a lot of the patient's sicknesses and symptoms relate back to. So it's, if you think about it like from an adult, especially an older adult, we are concerned about their heart giving out or becoming weak or there being a blockage. Like that's where a lot of times it's critical and the patient, may have devastating outcomes. For a pediatric patient, it's not generally the heart, though they can, of course, have cardiac issues, and Mistol is going to cover all of those. But what's more likely to be the cause of them declining or, actually arresting is if their lungs are impacted, if their breathing function is impaired. So a lot to look at in terms of respiratory. Okay, so this first condition that we're looking at, I don't actually have additional notes for. I put everything on the slide so that it would be very easy for you to review it. But with all of this, I would say going into your textbook is a really good idea. Not necessarily reading everything verbatim, but just getting into the sections of these specific diseases and conditions and seeing kind of how they portray it, because it might make it stick a little bit better for you than just having the slide and the lecture to accompany it. So we know that ear infections, we know that ear infections are very common in pediatrics, and we've talked about why already. It's from an anatomy standpoint, that they have a short and horizontal eustachian tube, which means that anything fluid-wise tends to collect instead of drain, which leads to infection potential. So we're going to expect to see ear infections pretty frequently. Otitis media translates as an infection specifically of the middle ear. And with that, basically, the description is acute inflammation or infection that can be bacterial or viral in origin. The only way to really know for certain is blood work for the patient, and sometimes, trial and error of seeing how they respond to antibiotics. So a lot of times, if they plan to treat the infection potential, then they're going to do blood work to determine what way the labs shift to see if it's probably bacterial or viral. Obviously, knowing that if it's viral, antibiotics are not going to be effective, and so in that situation it's more symptomatic care. We're going to be addressing the patient's symptoms, which are typically pain, so giving them pain reducers. Sometimes they have a fever, which would also help to reduce the fever, and that would be things like Tylenol and Motrin. Obviously, remembering that Motrin or ibuprofen, you have to be at least 6 months old before you can receive doses of it. Typically, the eardrum will be bulging, red, and even maybe opaque versus transparent when otitis media exists. There can be drainage, though that's not necessarily the case. And a lot of times it has a color to it and even a foul smell. We discussed already that there's pain involved and usually fever, maybe lymph node enlargement, especially beneath the ear and kind of coming down the jaw line. That's typically where they'll be palpated, and the patient may be pulling at their ears or constantly turning their head to one side based on this discomfort that they're experiencing. Okay, so that's one option for a form of ear infection. The other, or another, is OME, which is otitis media with effusion. So previously, otitis media, a lot of times you'll see it documented AOM, which means acute otitis media. Now we're talking about OME, which is otitis media with effusion. The key word in this one is E, or effusion, which represents fluid. So in this case, in the middle ear, what is present is fluid collection. Typically with OME, if it's diagnosed correctly, it does not involve acute inflammation or infection indicators. So this child would not be in pain and they would not be experiencing a fever. Their inner ear or middle ear would not look red and bulging. They would have fluid bubbles potentially, and the patient's complaints would include a feeling of fullness, or like they can't really hear very well. It sounds, full, or there's pressure. They may experience the ringing in the ears called tinnitus, and then it can impact their ability to hear. Like they can, obviously be in the vicinity of somebody who's talking or something that's making noise, and they don't have a clear understanding of what they're hearing. This will also affect their balance or their equilibrium. So disequilibrium is a possibility. Need you to know that a patient can have an acute otitis media infection, or AOM, with effusion. So they can have AOM with E potentially, and that is when there's the indicators of both infection and fluid collection. But AOM alone does not include fluid, just like OME alone does not include infection or inflammation that would be characterized by AOM. Okay, and then the other form of ear infection to consider is one that is not middle ear concentrated. It's actually external ear, otitis externa, abbreviated OE, and it is essentially what we refer to as swimmer's ear. So it is the consequence of water remaining stagnant in the ear and becoming infected. It's bacterial, so it would be treated with antibiotics. It is very painful, especially in a particular location of the ear called the pinna or the tragus. If you're pushing or touching on that area, it is very sensitive, hurts very badly. The actual ear itself itches severely, or has what we would call severe pruritus. And it is visible without any kind of equipment. Like for your middle ear infection or middle ear fluid collection, you're using an otoscope to be able to see that, symptom presentation. With this, from just looking at the patient, you can see that infection and that inflammation. Everything's going to be red. There's drainage, usually a purulent drainage, so it'll be crusted. It looks awful, and y'all are frequently telling me, give us pictures. There are some pictures in your book. You can also Google them online, and the activity we're going to do for this particular unit, the assignment that's going to be graded, is going to incorporate some photos as well. So let me tell you something important about this particular form of ear infection. Swim ear is a brand name or a product name for what is essentially rubbing alcohol, like 99% rubbing alcohol and I think 1% water or saline. It is used to dry out the ears after the person goes swimming. It would be the same as you putting rubbing alcohol in your ear after the person goes swimming, to get the water out so that it doesn't remain stagnant and become a portal for infection. Okay, swimmer's ear is preventative. Rubbing alcohol is preventative measures to keep the person from developing otitis externa, or by definition, swimmer's ear. It is not treatment. It's not management. And if you think about it, think about alcohol in the form of an alcohol prep pad and touching it to any open wound or cut you have, the pain that is resulting. If you put rubbing alcohol or this swim ear product on an already existing otitis externa infection, you will likely lose a finger from that child biting you, or if you're a man, you should beware of your sensitive regions being kicked, because it will be excruciating pain for that person. And even though I will say all of this, somebody will still on the exam choose, for management purposes, swim ear or rubbing alcohol to help the patient recover who has this diagnosis. But I'm telling you, please, please, please hear me loud and clear. Swimmer's ear, the other name for this infection, is once the water that was stagnant becomes infected, creating this problem for the child, we don't want to manage it with swim ear product or rubbing alcohol. That is only a preventative measure. Okay. All right. Additional things related to any of these ear problems. So otitis interventions. When we talk about supportive care, that is not antibiotics. That is when a patient has a viral infection, and so antibiotics will not help. Or if we haven't determined bacterial versus viral, but we're doing the essentially watch and wait or wait and see, and we're not prescribing anything antibiotic right now, that is your supportive care. We're going to talk about supportive care a lot more in this chapter and other body systems, that I teach. And that terminology always means the same thing. Relief of pain. So generally with pain reducers like medication or, non-medication interventions like distraction, guided imagery, heat or cool, depending on what's going on. It's anything that's going to provide pain relief. It's fever reduction. So if there's a fever involved, it's whatever measures you're taking to try to get that patient's fever down. It's maintaining hydration, adequate hydration, and a lot of times in conjunction with that is nutrition, but it's trying to help the body heal faster by making sure these elements are balanced. When we talk about antibiotics, that's not supportive care. That is its own management or intervention or treatment that is being done because we know whatever it is bacterial in origin. And know that, depending on the pediatrician and the child's age and their presentation, antibiotics are something that hopefully is still being prescribed conservatively, especially in our young kids. And sometimes we'll do what we call watchful waiting first to see if the body will treat or heal itself, because we don't want them to develop resistance to these antibiotics. If they do that, especially very early on in life, then that limits what we can give them later when they have infections that definitely need antibiotics, and you run the risk of the patient becoming, antibiotic resistant, and nothing but very aggressive medications will work for them. Having patients be up to date on their vaccines or their immunizations can reduce the frequency of ear infections that child will experience. Making sure the child's being fed in the upright position, limiting exposure to things like, say, tobacco or secondhand smoke, but even sometimes like pets, things that are going to create or trigger allergic response can also lead to this because of the fluid and sinus changes that are happening in this young and immature system. And then it mentions PE tubes, also known as pressure equalizing tubes, being placed in the eardrum, and that is something that is done not for every ear infection. For somebody who is having frequent ear infections, there's a criteria they have to meet for an ENT to even explore this option, and it's typically so many infections within a certain amount of time. And those infections can be, otitis media, which is that AOM, that acute with inflammation and infection potential, or it could be OME, which is without the infection and inflammation, but with the fluid, because both of those problems can contribute to the patient continuously having recurring infections or fluid, and it can impact their speech and their hearing. And I don't think that's discussed on this slide, but that is something we want to evaluate. These are young kids that are typically having this problem, they're also in a very important stage of life where they're developing speech, both receptive and expressive communication. So sometimes we'll see a child who seems delayed in that, and then they'll go and have tubes placed in their ears, and next thing you know, they're saying all kind of stuff because now they can actually hear to then repeat and learn the vocabulary that they're now able to audibly hear. Okay, next condition, sinusitis. This one is obviously the sinuses, and it's associated with inflammation of the sinuses, and it's usually due to mucus that doesn't drain and ends up creating or harboring bacteria, viral infection, or even just allergic irritants, the allergen invasion. A signature manifestation for this would be facial pain and tenderness, especially a headache. Discharge is pretty common, and it usually is colorful, like yellow or green. They can experience some swelling. Many times this patient will have what we refer to as a post-nasal drip, so it's like dripping in the back of their throat, which is creating this foul odor or bad breath, which we call halitosis. Because of that post-nasal drip and that halitosis, sometimes this patient experiences GI upset. It's not true vomiting or nausea. It's because of this mucus that they're swallowing, and that is, staying in their throat or reaching their stomach. So some ways that we can manage this would be warm compresses placed on the face in the areas where the pain and tenderness is most intense, using a cool mist humidifier, because that's going to thin your mucus secretions and allow them to be expelled or excreted. Knowing that this will typically last up to 14 days or 2 weeks. With a sinus infection, it's usually not a immediate resolution. And something that could be done for it possibly is use of antihistamines, especially if the assumption is it's allergen related. Then they can be prescribed, or even over-the-counter antihistamines can help with it. Okay, nasopharyngitis. Think about it from a medical terminology standpoint. That's what the structures involve, so the nose and the throat. It means there's inflammation of nasal and throat mucosa that can be bacterial or viral in origin. And if it's bacterial, then we often see the patient experience a sore throat, and they will respond to antibiotics. Nasopharyngitis is very common in winter months, so it's the season we're approaching, and it usually lasts anywhere from 4 to 10 days, so up to a week and a half, and it's characterized by a lot of nasal congestion. So this is one that's usually more manageable. They don't typically have fever. They don't end up needing to be hospitalized. They're not without the means of going to school or daycare the entire time that they're battling this. It's usually something that will resolve if it's viral within that time frame. If it's bacterial, it'll respond to the antibiotic pretty easily. Okay, pharyngitis means we're removing the nasal element of it. So like that nasal congestion we talked about previously would not be the case here. And this is strictly the throat. So inflammation of throat mucosa and the structures that underline it. Can still be bacterial or viral. If it's bacterial, it's often the Streptococcus bacteria, which is why we think of a sore throat as often being called strep. Strep is not just another name for a sore throat. It is the type of bacteria infecting the throat that gives it that name. It could be other bacterias that are causing it, in which case the strep test would come back negative. It could be viral, and that's why it comes back negative for strep. And oftentimes if it's viral, it's the adenovirus. and that is more often seen in the late fall and winter months, so basically the season we're upon. With this particular infection and inflammation, the typical symptom presentation includes a sore throat, includes fever, the feeling of throat swelling, like it's harder to swallow, maybe to talk than usual. And in pediatrics, sometimes we'll see what they refer to as a sandpaper rash, which is what we would also call a signature of scarlet fever. And that is if its origin, if this pharyngitis' origin is group A strep specifically. In pediatrics, another way that strep can typically present that's not as typical in your adult population is abdominal pain and GI upset. So, the patient could experience nausea, vomiting, diarrhea, and that be associated with pharyngitis, and then also headaches, which they may or may not be able to verbalize, but it's something that you'll see them reacting to. Okay, so interventions that are generic for all of these: sinusitis, nasopharyngitis, and pharyngitis. We want to make sure that we're monitoring the respiratory status of the child, because obviously if their nose and throat are involved, then that's part of the airway. They could have respiratory decline. We also want to make sure that we're paying attention to what is the clinical presentation, because that will help us with a more accurate diagnosis. And we're not diagnosing, but obviously the assessment that we're presenting to the provider who's going to make that diagnosis. Talked about supportive care already. We talked about antibiotics if the infection is bacterial. Okay, influenza or flu. This, of course, is viral, so antibiotics are off the table, but there is a medication. There's more than one now. It's an antiviral medication that can be utilized if symptoms are detected early enough, and you probably heard of Tamiflu and Xofluza. Tamiflu being a multiple pill or multiple tablet treatment. Xofluza is a single pill that you take for the infection. This is spread through contact and droplets or inhalation, and impacts the upper respiratory tract. And typically your symptoms are very abrupt in onset and include fever and chills, a flush cheek, so like that pink discoloration, complaints of a headache, coughing and other cold-like symptoms, a general malaise or like overall tired feeling, lacking appetite, muscle aching, all of that. And then for pediatrics, a lot of times they'll also experience a rash, a red rash. We see flu all year long. It used to be very much a seasonal thing. It is definitely more prevalent in winter months, but it's not isolated to just winter months anymore. A person can be contagious for up to a week from when their symptoms start. And so a lot of times these individuals do need to keep a safe distance from other kids or anybody immunocompromised the duration of their illness. And there is a vaccine for it. That is, a child as young as 6 months can receive the vaccination, and into the elderly as far as how old you can be and still get it. And so it is one that is needed every season. It's not one that you get as a small child and it protects you for every flu season thereafter. And that is to do with the variety of strains of flu that happen every year. And basically, some scientists are predicting what they think are going to be the most common strains that upcoming season. And that's what they're putting into that vaccine for people. So those antiviral medications we already mentioned, supportive care, which would be the pain relief, the fever reduction, the adequate hydration. Because coughing typically is a symptom, sometimes there will be instructions to take a suppressant, especially if that's needed for the patient to be able to eat without throwing up or to be able to sleep. so that their body can rest and heal. We don't always want to suppress a cough because a cough is a means of getting rid of an infection source. So if you suppress it, then you keep that cough, you keep that infection in the body longer. Lots of rest. Wearing a mask will help to minimize spread to others, so will frequent hand washing, coughing into the elbow or the sleeve instead of the hand to further reduce spread. Tonsillitis. This is going to specifically focus on our tonsils, but we'll talk about adenoids as well. And, itis meaning the inflammation or enlargement of the tonsils, potentially also the adenoids, and it could include infection. So we've got different forms, just like we've had previously, bacterial or viral in origin. More often tonsillitis is viral, because usually if we're talking about a bacterial form, it's actually the throat that's involved, and that's that pharyngitis. With this, the child experiences difficulty swallowing. It's very painful to swallow. They typically do run a fever, and there's usually evidence of this on the throat itself in the form of little white patches or white spots. We see this most often in our preschool children between ages 4 and 7 years old. A difference with this one is that there's usually not the abdominal pain or headache complaints that we saw with strep or pharyngitis, the slide previously, but they do have some drainage that contributes to them having that foul or bad breath. So halitosis is something else we would expect with tonsillitis in pediatrics. And so our care is supportive, especially if we've determined it's viral. If a patient's experiencing this frequently enough, they may be a candidate for a tonsillectomy to have that and potentially even their adenoids removed. If a patient experiences a tonsillectomy, it's some important things to note that you want to be aware of in the post-op care. The patient's position should be side-lying, and that's to help with drainage and prevent choking and aspiration. The patient should avoid using a straw and eating anything that's sharp or acidic because that will irritate the area. We want to monitor for hemorrhaging or bleeding, and one way that could be indicated is if the patient's frequently swallowing but they don't have anything to swallow. So it's not like I'm taking a sip of something and I'm swallowing. It's like I just keep, because I'm having something drip or drain in my throat. To help them to eat adequately, they will likely recommend pain meds before mealtime. That way they'll want to eat something, because a lot of times we'll see some refusal to eat during this post-op period because of the discomfort. And then, again, in terms of care, if it's bacterial in origin, then antibiotics would be an appropriate treatment measure. Okay, so the last two conditions within the upper airway infectious disorder category are croup and epiglottitis. So starting with croup, croup is a term that basically means inflammation in the airway, upper airway structures that results in the following manifestations. A barking or seal-like cough, seal like, the animal. Stridor, which we talked about being one of the adventitious lung sounds, specifically the one that indicates the most severity. Respiratory distress, which can be manifested in many ways. And hoarseness, so the patient's actually losing their voice, or there's a very deep or low sound to their voice. These symptoms apply to all forms of of croup, except for the type called acute laryngitis. So if you look on this slide, right beneath what I just finished explaining, it says there are 4 types of croup. There's acute spasmodic laryngitis, also known as spasmodic croup. There's acute laryngitis, there's laryngotracheitis, and there's laryngotracheobronchitis. And obviously they're differentiated based on what structures are involved as far as inflammation and infection goes. So of these 4 types, all of them are going to have these characteristics: the barking seal-like cough, the stridor and other distress indicators, and the hoarseness, except for acute laryngitis. Acute laryngitis is the most minimal of the 4 as far as compromising respiratory functioning, and the only symptom it's going to have is hoarseness. Basically, this is when you lose your voice, but you're not in any kind of pain. There's no indicators of infection, no fever, no inflammation. It doesn't hurt, but all of a sudden you can't talk, or when you try, there's very little sound that is formed. A great scene that I will always think of when I think of acute laryngitis is from the movie Walk the Line, which is based on the story of Johnny Cash, and he and June Carter Cash are having a conversation about how he hasn't called, or maybe she hadn't called, I don't remember, but basically one of them says to the other, "What, you got the laryngitis?" Which basically just means you have no voice. That's why I didn't hear from you. So it is the one that is not accompanied by respiratory distress indicators. Since we're on it, I'll go ahead and finish. Acute laryngitis, it can be viral or bacterial as far as it's a reason for occurring, or the infection that's causing it. It's possibly going to have a gradual onset, so like you start to lose your voice before you actually have no voice. And I think I may have said on the last slide that there's not pain. There can be some discomfort with speaking and swallowing, but it's not pain like if you think about, strep throat kind of pain, or even tonsillitis kind of pain, where it's like always burning, you want to just numb it however you can. It's the least severe. It is self-resolving, which means even in its bacterial form, it doesn't necessarily require an antibiotic, because the infection is essentially so minimal. But if they do determine it to be bacterial, they'll probably give a antibiotic with it. But it doesn't generally compromise respiratory function. Okay. Acute spasmodic laryngitis, that's the one I want to speak to next, is the first one on this slide, is what we most often think of as spasmodic croup, and I don't know how many of you have actually heard that, whereas laryngotracheobronchitis, the last one on this slide, is what is often referred to as just croup. So you may not have realized, kind of like if you didn't realize that strep or strep throat is not the only way that strep can affect your body. It's just a type of infection, normally in sore throats. If it's streptococcus bacteria, then it's called strep throat. Okay, so laryngotracheobronchitis and acute spasmodic laryngitis. These 2 of the 4 are the most similar, but there are some very important differences. If you memorize these differences, you will do fine with this content on an exam and in clinical practice. But the really only way to do that is to study it to the point of memorization. Okay, both of them are viral. Acute spasmodic laryngitis or spasmodic croup, and laryngotracheobronchitis, often referred to as croup. They both have an abrupt onset. The difference is that with acute spasmodic laryngitis, it's more intermittent, and the problems or the symptoms are worse at nighttime. So it comes on quickly, but it doesn't affect them all day, every day. And it is more noticeable, worse for the child at night. This one does not include fever generally. Now you'll have to keep in mind that with medicine, healthcare, medical, anything, are still going to have exceptions to the rule, okay? But generally, there's not a fever with this form of croup syndrome. And the children's ages that we see most often impacted are the younger child, the infant toddler, from 3 months to 3 years. Okay, so viral in nature, abrupt onset, but it's intermittent, so it's not constant all day, every day. Worse at nighttime, not typically characterized by a fever, and in our infant toddler population. The other, laryngotracheobronchitis, which we said is more of the, just understood croup, viral, impacting upper and lower airway, so more structures involved because larynx, trachea, and bronchi are all impacted. The symptoms for this are worse when you get to about day 3 to day 5. So it may come on rather suddenly also, but it's not going to immediately be at its worst. It's going to get worse before it gets better. And this one's age frame is 6 months to 6 years. So it's our infants and toddlers, but it even extends into our preschool kids. So one thing I can tell you for exam purposes, if I'm asking a question and I'm expecting you to differentiate between acute spasmodic laryngitis and laryngotracheobronchitis, I will find a patient, or I will give an example of a patient whose age only falls under one category. So I will say they are 5 years old with this viral infection that, is creating hoarseness and what were the other things on the previous slide? Some respiratory distress, stridor, I don't know what the other one was. Okay, I'll give the symptoms that overlap, but I'll throw in something that differentiates. So it's either going to be the age of the child, or it might be that it's worse at nighttime, or it might be that it's intermittent, like something to help you differentiate the two. Okay? Okay. So what do we do about croup? The interventions for croup include humidified air, because this is something that is resulting in inflammation and secretions, so we want to try to thin that, help counteract that inflammation, making it easier for them to breathe. If they're hospitalized, they're likely going to be on supplemental O2. They're going to need to rest a lot. We want them in a comfortable and calm environment so that they can heal and get better. We want them to stay hydrated, but we're going to avoid anything acidic that's going to then cause more discomfort for them. The patient will likely need some medications prescribed that will decrease inflammation and minimize mucus or sputum production. So examples would be racemic epi. That means it's like a nebulized form of epinephrine that has like rapid onset and can last like 2 hours. So it'll give them some relief pretty immediately for about a 2-hour window. But then corticosteroids can be prescribed that have effects for longer acting, so can kind of come in as the racemic epi is wearing off and provide more relief, knowing though that steroids do affect blood pressure and they affect glucose levels in the body. This is a contagious condition, but it's mostly contagious to other kids. It's not to say that a person who has it, a child, can't get an adult sick with it. They can, but typically adults have already developed the immunity through antibody production against group. So you'll find that, and this is something we talked to the F.A. Davis rep about, in your textbook, it actually has it listed as a non-contagious, or how did they say, non-infectious condition. But that's not accurate, because it is infectious, it is contagious to other kids. So you do still want to take the necessary precautions to try to prevent spread of it. Okay, epiglottitis is our last infectious upper airway disorder in this chapter. Of everything we've talked about so far, this is the one that is the most severe, life-threatening. It is rare in the United States, thank Jesus, but it does still happen. There are still cases of it, and the children who are most susceptible are kids between ages 2 and 8 years old. So toddler, preschool, and then even early school age. Okay. What has helped it to be rare in the United States is compliance with immunizations, with vaccines. So when we have a lot of kids who are up to date on their vaccine status, we don't see this. But if it's a area or a state, or if you leave the country and you're in regions where vaccine compliance is lacking, then the reality is breakthrough cases of things like this are more likely to occur. Okay, epiglottitis, which is inflammation of the epiglottis, inflammation and infection, is bacterial in origin every time. But you don't know what bacteria is creating it. So with this particular infection or this disorder, a lot of times the initial treatment is a broad spectrum antibiotic until we can get a sputum culture and determine what specific bacteria is causing it. And then the child will be, switched to whatever is the necessary antibiotic specifically for the bacteria that's creating this infection. With this, there is rapid onset of inflammation and infection of the epiglottis. Remember, that's the structure covering the windpipe. And the patient's going to manifest the following description. Sudden high fever, like 104, 105 high fever. Severe sore throat. Coughing and adventitious or abnormal breath sounds. Those breath sounds can get to the point of the patient's lung sounds being diminished because of the degree of inflammation and obstruction of the airway. So what you would not expect is for the lung sounds to be clear, but what you might experience is that the lung sounds become diminished or barely auscultated, and that is not an indication of improvement. That is bad, because that means that no adequate ventilation is occurring for this patient. Those things I just listed, plus the 4 Ds and an S. Okay, it talks about the 4 Ds in your book, so we're going to call it the 4 Ds and an S. The 4 Ds are drooling, so they are having secretion production that they are not able to swallow, so they're drooling. Dysphagia, which is difficulty swallowing. Distress, which we know has many forms of presentation, but would be distress of the respiratory system or function. Dysphonia, which is an alteration in sound, like their vocal sound. And then stridor, which is the lung sound where we hear the high pitch, almost like a wheeze, but it's with inspiration due to obstruction. This is the child that I spoke earlier about the tripod position, where they will likely be sitting upright, hands on their knees, neck and body extended, leaning forward, because they are starving for air. They are trying to oxygenate as best they can. So one thing we never want to do for this patient is try to force them in a position that compromises their breathing. They're not going to go lay down. Like, you're not going to tell them, okay, let me let you lie here and see if that helps. No, they need to be upright, completely elevated, high Fowlers, in whatever position is most comfortable to them that allows them to try to receive some oxygenation. Obviously, you would expect vitals to be rapid, so tachypnic, tachycardic, the patient to be anxious and restless because they're scared, because they can't breathe. What are we doing about it? This is another important slide because it doesn't look the same as any of the other conditions we've discussed thus far. Minimize stimulation. So one thing that is alluding to is not trying to get a sputum culture right away that tells us specifically what bacteria. Y'all, I'm sorry. I'm trying. I even took a nap before recording this. Yes, knowing the bacteria that's triggering this is vital. And as soon as we do, we can give IV antibiotics that target that bacteria specifically. But if we do anything to increase stimulation, what is likely to occur? The airway will be obstructed completely. If it's completely obstructed, the patient receives no oxygen. If they are not breathing, they are not alive, okay? So what is priority is maintaining or creating a patent airway for the patient, likely in the form of intubation. You are not doing that as the nurse, but you are assisting that happening, and you are recognizing that needs to come before some of the other measures that do fall on you as the nurse. So you'll see oxygen, supplemental oxygen in the form of 100% oxygenation, and then in parentheses, non-rebreather. We'll get to this more at the second part of the respiratory lecture, but we know there's different oxygen delivery devices, and as we go through them, they are giving us a greater percentage of oxygen delivery depending on what we're choosing. Like nasal cannula is the minimum, and a mask or simple mask is the next, and a non-rebreather follows that. Venturi isn't necessarily the best or the highest, but it has the ability for titration for like a patient who, say, has COPD and we don't want to accidentally over-oxygenate them. So for this patient, the only thing beneficial is going to be a non-rebreather, which is the one that's the mask on the face and there's a bag attached that is, inflating and deflating, and they're basically recirculating the same air they are expiring. This would be oxygen turned up all the way, 15 liters, and you do this before you put the mask on the child. This is important, and honestly, I don't know that I learned this in school, but your book talks about it, and it does seem pretty vital to know. So you want to connect it to oxygen, turning the oxygen up all the way before placing the mask on the child's face. This is what will allow for adequate deflation and inflation of the bag with each breath, giving you the ability to deliver 100% oxygenation. If you don't do it this way or in this order, then you will actually compromise the ability to provide 100% oxygenation to the patient. Now, even though I've got 100% oxygen on this patient, if I don't do something to interrupt the swelling and the obstruction of the airway, Is 100% oxygenation going to matter? No. If it can't get from nose and mouth to lungs, it's not doing me any good. And the passageway it needs to get there is where this current problem exists, this obstruction associated with inflammation. So yes, I'm doing this as quickly as possible, putting them on 100% oxygenation, non-rebreather, 15 liters. But simultaneously, I am getting the materials together and a provider who can do the intubation, because we need to guarantee patent airway. If intubation is not possible because of the degree of swelling or the non-visibility of the passageway, the alternative is to trach the patient, to create an artificial opening in the trachea called a tracheostomy, where a cannula is inserted to maintain that airway. And that would hopefully be reversible. They would not be dependent on that forever. They would need that until this infection has cleared, and then they would be able to take that tracheostomy tube out and allow that stoma to heal. Once airway is secured, so we are either intubated or the patient has been trached, that's when we want to do the culture that will determine what specific bacteria the patient has that needs a specific antibiotic IV. So we don't go trying to get that until after that airway is guaranteed patency. And that's why, again, we'll use a broad spectrum first. And our additional measures are to promote hydration, and since it's going to need some kind of antibiotic treatment, medication compliance for this patient. Okay, what is left? Just a couple that are non-infectious airway disorders involving the upper airway. And I made a slight reference to these earlier when I said there was going to be some structural abnormalities that could result in stridor, and it be what we would consider chronic stridor, not acute stridor. That's what this is right here. Your book actually labels it something different. I don't remember if I included that on the slide, but it doesn't refer to them as laryngeo and tracheomalacia, so you'll have to look in the chapter, but it's talking about the same thing. Okay, these next couple of terms I'm going to use, they would best be memorized, remembering your medical terminology, because that will help you to understand what's happening with these different disorders or conditions. Pretty much all of this that I'm about to talk about pertains to a premature infant, a baby who is born early, and not just like 36 weeks, but like significantly early, like somewhere in the 20-week, 24, I think is what we agreed is viability. So like 24 to 32 weeks, somewhere generally in that time frame. Okay, several months early. Okay, so when a baby is born early, they didn't stay in the womb or the utero long enough for all of the normal gestational development to occur. Some of that gestational development involves the airway structures. So the larynx and the trachea should have two things happen before the baby is earthside, or, out of the womb. The larynx and trachea should have cartilage that is firm, not floppy, and they should have a certain diameter that there is, easy passageway for ventilation to occur. When it's not firm cartilage, when it's floppy or flaccid, that soft tissue cartilage that's floppy or flaccid is what we refer to as malacia. So if it's involving the larynx cartilage, then it's laryngomalacia. If it's involving the trachea cartilage, then it's tracheomalacia. If we're talking about it from a narrowing versus being wide enough, which is going to be the next slide, then it's referred to as stenosis. So if it's the larynx that's passageway is very narrow, it's laryngeal stenosis. If it's the trachea that's very narrow, then it's tracheal stenosis. Okay, so on this first slide, laryngeo and tracheomalacia, cartilage abnormality in which it's soft and floppy in the corresponding location that results in a possible airway collapse. This is congenital, it's from birth, and it's chronic because what is actually going to resolve this? I know you can't be heard right now, but the correct answer is time and growth. This is a preemie who needs to get bigger. And as they develop now outside of the womb, then eventually their cartilage will be the rigidity it's supposed to, and this will no longer be an issue for them. So what this baby is likely to experience is stridor on inspiration, and it may even resemble a crowing noise. The baby can have indicators initially of distress like retractions, tachypnea, cyanosis, grunting, nasal flaring, all the different things. Like this baby is going where when they're born? The NICU. They're going to have all of the tubes and cords and interventions galore to stabilize them, okay? But eventually, this baby is going to graduate from the NICU and get to be in the nursery or get to go home with the parents because they're going to have the right body temp, they're going to have the right weight, they're going to feed efficiently, they're going to get to go home. But they may still have this stridor sound associated with their breathing or their lung sounds until enough time has passed that growth and maturation has occurred. When they have gone home and they're still experiencing this, we know it's this chronic stridor that's not concerning as far as compromise of respiratory functioning because there won't be any other indicators of distress. This child will not have abnormal heart rate or breath rate. They will not have cyanosis. They will not have retractions and other accessory muscle use. They'll just have the sound associated with their lungs. And obviously we'll know it too because of their medical history. Oh, they were born at 26 weeks gestation. They were in the NICU for 7 months, yada, yada. Okay? These babies will also likely need smaller frequent feedings versus larger, less often feedings because we want it to be able to pass without creating an obstruction. And then maybe even like an anti-reflux medication like Zantac that will help them to keep it down so that it's not, causing indigestion or heartburn and regurgitation. We expect that this will on its own resolve by the time the patient's 2. And if you remember in class previously, we discussed how usually most premature babies are caught up in every sense of the word by age 2. Okay, very similarly to what we just went over with laryngeo and tracheal malacia, now we're talking about laryngeal and tracheal stenosis, which is the narrowing of these structures. Here's that other term. So in your book, it refers to it as subglottic stenosis, which is those same 2 structures. Again, congenital at birth, but it could be acquired. And with that, acquiring it would be from repeated or prolonged intubation or illness. So if the patient has to be intubated frequently, like they're intubated, then they're extubated, then they're intubated, then they're extubated, that can create scar tissue that will then narrow these structures. Or if they have infection that's essentially long-term or chronic, then it can be the reason for continued or persistent inflammation that narrows these passageways. So typically with this form of stridor, you don't even need your stethoscope to hear it. Like, yeah, that's how we hear, breath sounds, and we're listening for adventitious ones, but this would be heard just being from you to me with this patient. Reflux is still a concern with them. That does usually result in further irritation and inflammation, so they may need an anti-reflux medication. Oxygen, definitely. Suctioning, definitely. When this kid is first born and they're in the NICU, maybe even surgery to have a tracheostomy, a tube placed that will ensure that airway patency. But that should all be reversed. Like, eventually they won't need it, because eventually the body's going to compensate, and they may have this stridor, but they won't have any of the other distress indicators either. Okay, and that concludes our first part of the respiratory lecture. I know it was long, and I know I spoke a lot, but hopefully you'll find that the description and depth to which I lectured it is helping you to get a good idea of these different disorders and conditions and how they differ from one another. When you start part 2 of this lecture, we will be focusing on the lower airway. So everything thus far has been upper airway focused, both infectious and non-infectious, and now we're going to pick up in this next recording with lower airway infectious. All right.